So welcome to this online session of ophthalmology from Joint Center International Eye Center. I'm Dr. Wang. Today I'm going to share with you something about refractive error, which may be closely related to everybody's daily life. By definition, an accommodative eye with distant parallel lines focusing on the retina is called a metropic eye. Otherwise, we have refractive errors, including hyperopia, focusing behind the retina, myopia, focusing in front of the retina, and astigmatism, focusing with multiple focal points. Refractive error has been the leading cause of visual impairment in the world for some time and is on increase in most places. Myopia, the most common type of refractive error, has caught our attention due to its high prevalence here. Myopia development is a result of interplay between genetic and environmental factors. Genetic factors are clearly involved, but myopia is also associated with education, the amount of time spent on reading at close distance, and under suboptimal conditions. In clinical practice, myopia can be classified according to the degree, refractive component, or pathological changes. Myopia over 6 diopters is called high myopia. If the eye is longer than average, the error is called axial myopia, which is the most common type. For each additional millimeter of axial length, the eye is approximately 3 diopters more myopic. If the refractive elements have more refractive power than average, it should be refractive myopia. And if there is complications such as macular bleeding or retinal detachment, we call this pathological myopia, more commonly seen in people with high myopia. A myopic person has poor distant vision and prefers to squint his or her eyes to see better. But they have the advantage of being able to read without glasses when they are older. It has been proven that accommodation relaxation, such as outdoor activity, was beneficial for myopia prevention. Atropine eye drops and also keratology lenses are useful in slowing down the development. To correct myopia, we use concave spherical lenses which move the image back to the retina. Refractive surgery can be considered for adult patients who prefer not to wear eyeglasses. Also, don't forget to screen and treat the myopia-related complications. On the contrary, hyperopia is a more difficult concept to explain than myopia. The term farsightedness is misleading, since parallel lines raise focus behind the retina. A hyperopic eye should increase its refractive power by accommodation all the time. Therefore, eye strain is a common complaint, which is more severe for near vision. And with age, the symptoms intensify due to the loss of accommodation. But remember, farsightedness doesn't mean good distant vision. Once the accommodation fails to compensate, distant vision is also affected. And as you can imagine, the near vision is even worse. In addition, due to the correlation between accommodation and convergence, hyperopia is a frequent cause of accommodative astropia, which can be reversed when the hyperopia is fully corrected. The uncorrected high hyperopia may lead to amblyopia in children. We don't need to correct low hyperopia without eye strain, but we should recommend corrections if the degree is moderate or high, or the patient complains about fatigue or astropia. To get that image on the retina, we have to add refractive power by using a convex lens. These convex lenses are just your traditional magnifying glass and can make the patient's eye look enormous. Astigmatism is somewhat different with myopia or hyperopia. It refers to the eye producing an image with multiple foci, instead of one single point, due to different radius of curvature along different meridians. A survey for normal eyes shows that almost every human eye has a baseline astigmatism. Astigmatism can be natural or induced by ocular surgeries or disease. It can be the result of asymmetry of cornea or lenses. Classification of astigmatism is commonly determined according to the axis of the principal meridians. Regular astigmatism refers to the situation that the two principal meridians are mutually perpendicular, which can be corrected by eyeglasses. And it is called with the rule when the steepest meridian is close to 90 degrees and against the rule when the steepest meridian is close to 180 degrees. We also can classify astigmatism as simple or compound types based on whether only one or both meridians are focused outside the retina. If one meridian focuses in front of the retina and the other focuses behind it, the astigmatism is called mixed. The differences of refractive power between the two meridians is called degree of astigmatism, from mild to severe. In regular astigmatism, each of the principal meridians produces a linear image at its focal distance. Take with the rule and simple myopic astigmatism as example, in which the cornea is like an egg with greater refractive power at 90 degrees. A line spot converges firstly in vertical orientation to form a horizontal focal line in front of the retina, and then diverges in vertical orientation and convergence in the horizontal orientation to form a vertical focal line right on the retina. In the space between the focal lines, the interval of stem, the closed section of image is oval. Only in one position, the closed section will be round, which is called the circle of least confusion. Therefore, in an eye with the rule and simple myopic astigmatism, a line spot will appear in a form of vertical trailing. In a similar fashion, this patient will feel that the vertical lines are clearer than the transverse line, and a vertical E letter is much easier to distinguish. So have you ever been asked to finish this test? This chart is commonly used to check whether or not the patients have astigmatism. Look at this clock chart, which, if any spokes are darker. In astigmatic eyes, one or two lines appear more prominent and darker, whereas without astigmatism, these lines appear equally dark. Manifestation of astigmatism includes blurred or distorted vision, visual strain, and double vision. Sometimes the patients are found to have habits of squinting or head tilting. Regular astigmatism often can be corrected with cylindrical lenses, or sometimes more effectively by alerting corneal shape by rigid contact lenses, which are usually the only optical means by managing irregular astigmatism. In recent years, you can also consider the refractive surgery. So finally, let's talk about anisometropia, which means differences in refractive error between the two eyes. These patients often have monovision because they fail to fuse the image from both eyes due to the differences in retinal image size and sharpness. Anisometropia is a frequent cause of unilateral myopia. Correction by eyeglasses is difficult to accept, so we recommend contact lens or refractive surgery. A routine record of refractive result contains the diopters of spherical and cylindrical lens and the axis. But the refractive result alone is not enough for giving a prescription for eyeglasses. Attention also should be paid to the balance between the two eyes, patient's visual need, age, and the rate of change of refractive error. In summary, refractive error refers to the unsatisfactory focus of light. Glasses, contact lens, and surgery are choices for correction. And trust me, you don't need to kill yourself memorizing these confusing concepts. Just get familiar with the subjects unless you want to be an optometrist. Here are the references. Thank you very much for joining us.